There are a number of tools that have been developed, validated, and incorporated into practice in the geriatric oncology literature. And what those tools can range from short screening tools that are designed to help identify older adults who would benefit from a comprehensive geriatric assessment as performed by a multidisciplinary geriatric assessment clinic. There are also tools that are developed with a goal of identifying patients at greater risk for chemotherapy toxicity. Those can include tools such as the Cancer and Aging Research Group Toxicity Tool or the CRASH tool Martine Exterman's group has developed. And these tend to utilize summary scores of the different domains of geriatric assessment. And in those two tools, they've identified groups of patients who are at greater risk for chemotherapy toxicity in those populations. Other different tools can be used to look at specific domains of the geriatric assessment to help identify patients with vulnerabilities in those specific subdomains, such as cognitive impairment, depression, function, and so forth. The goal was to help clinicians identify resources and approaches to assessing an older adult with cancer that could be easily implemented into their clinic. The idea is to help dispel the notion that incorporating assessment of geriatric domains into a busy oncology practice was an insurmountable task. And I think we need to work towards making, preventing the perfect from being the enemy of the good. An oncologist cannot fill the full purpose of a geriatrician. They have specific, unique training. So I think it's first important for an oncologist looking to use the tools of a geriatrician to identify what is their goal of using those tools, and then identify those that work in their clinical workflow. If the goal of the geriatric screening is to identify those who need a consultation with a geriatrician, a screening tool such as the G8 or gait speed would be a great first place to start. If the oncologist is aiming to use the information gleaned from that screening to identify the patients who are at greater risk for chemotherapy toxicity, to inform that conversation about treating the cancer, tools such as the Cancer and Aging Research Group tool, the CRASH tool, would be the appropriate tools to use in that setting. Both the CARG and the CRASH tool have online versions that can be utilized, accessed from the internet and utilized at the point of care in the clinic. Absolutely. I think knowledge is probably the first tool, and developing a level of comfort with using them. Whenever one is entering a new discipline, it can feel unfamiliar. And so I think I would encourage clinicians who are interested to start small, pick a tool and develop a level of comfort with it and how to interpret those findings. And time is always considered a barrier to this. Many of these tools, the Cancer and Aging Research Group tool and some of the CRASH components, can be self-administered, and so that takes the burden off of the clinician. I think moving forward, some of the exciting areas to help facilitate incorporating the principles of geriatrics into the oncology clinics will include using these self-reported platforms and then using them on electronic platforms that actually calculate the scores, which feed directly to the clinician a summary of those, pointing out the vulnerabilities that are potentially of greatest impact in this particular patient and how those might influence their thinking about treatment recommendations or the shared decision making regarding treatment. Certainly there are challenges in considering applying these tools in low middle income countries where the access to care is challenging, and there are barriers even at the cultural level about perceptions about treating care. There are perceptions in many cultures that a diagnosis of cancer is a death sentence, and so simply engaging the conversation about undergoing any treatment may be their first step. Using these principles of geriatrics may help refine the treatment so that we can minimize the treatment-related toxicity to help encourage the perception that treatment can be tailored. Treatment does not necessarily need to be so burdensome, so toxic, that it prevents a patient from meeting their goals of care. As far as other barriers of implementing this in other resource-poor settings, the multidisciplinary nature of geriatrics can involve multiple specialists of our allied health professionals, occupational therapists, physical therapists, nursing, and so on. There may be barriers to having the various members of a multidisciplinary geriatrics team available to participate in that treatment planning and treatment and interventions.